Hello, this is Chang Chien, and welcome to my talk on Introduction to Regenerative Medicine. I'm currently the Director for Pain Management, as well as the Director for Physical Medicine and Rehabilitation at Ventura County Medical Center. I also have a private practice where I practice primarily regenerative medicine and medical aesthetics, called the GCC Institute, located in Irvine, California. My disclosures are, I am a speaker for Apex Biologics. My goals for your course are, number one, to introduce you to this course and to present to you some unbiased, updated, evidence-based medicine. I'd like to challenge the current treatment dogmas that we have for common musculoskeletal and pain-related complaints, and I hope that you have an enjoyable time. My goals for you, as a participant in this course, is for you to be able to appreciate the diversity and the promises of regenerative medicine, and to act upon that in an ethical, evidence-based manner, to be a good shepherd for these therapies, and to never stop learning. To accomplish that over this weekend, we're going to be talking about the evolution of the field. You're going to be getting fantastic lectures that overview the basics of regenerative medicine, what's the difference between PRP, the different types of it, stem cells, bone marrow versus adipose, allogeneic products, etc., and how this translates to clinical practice in an evidence-based manner. We've worked hard to recruit some of the best speakers and brightest minds in this field to present to you the best knowledge that is available to date. You might recognize some of these speakers. They have been presidents of American and international organizations on regenerative medicine and pain management. We have worked hard to recruit people to represent the international community on treating musculoskeletal disease, medical aesthetics, as well as sexual dysfunction. The educational offering from this course includes leadership from multiple specialties, including anesthesiology, physical medicine rehabilitation, orthopedic surgery, and family medicine. We're going to be going over how to perform these regenerative medicine procedures both with fluoroscopy as well as ultrasound. There are also excellent lectures on business development, lead generation, and how to grow your medical practice. Richard Rosenthal will discuss the FDA updates for regenerative medicine, which has become a huge topic, especially during this year. We're going to be talking about some landmark studies on intradiscal BMC and best practices for intradiscal procedures. So a little bit about my practice. I practice conventional near-axial procedures using fluoroscopy. I also perform multiple types of ultrasound-guided procedures for regenerative medicine, as well as for pain management. This is a sampling of some of the things I do in my regenerative medicine practice that are related to medical aesthetics. Now, people ask me all the time, what is the overlap between treating pain with regenerative medicine and performing medical aesthetics procedures? You'll notice that a lot of these devices that I'm using here, this highly focused ultrasound, or even radiofrequency ablation, or laser treatments, are actually focused on causing microdamage to the skin and allowing for the skin to heal on its own. This is not dissimilar to when I perform a percutaneous tenotomy or intratendinous or intraligamentous injection. Continuing with the theme of the evolution of care, I'd like to point out something from the historical context. Trephination, where people would essentially drill a hole or perform a craniotomy, has been in practice for thousands and thousands of years. The thing with this is that although it was identified as early as 6500 BC, it was practiced for the millenniums up to the 16th century. And although the 16th century happened many, many years ago, even though it was marked by the Renaissance period where we learned greatly advances about science and astronomy, more recently, characters or physicians such as Walter Friedman were performing and promoting frontal lobotomies. It is interesting because these frontal lobotomies were performed oftentimes with something as simple as an ice pick, without wearing gloves or sterilization in front of large crowds and audiences in auditoriums. Now, as barbaric as this seems to us today, he still has patients that are alive today. So briefly during this talk, I'm going to be covering the what, the why, the when, the where, and the who in regards to regenerative medicine. So what is regenerative medicine? Well, by definition, it is the process of replacing, engineering, or regenerating human cells, tissues to restore normal function. Although I primarily work in the musculoskeletal system, as well as the dermatologic system, a lot of this data actually comes from cardiac and neurologic, as well as endocrine data. There's certainly going to be a lot of interest in figuring out how we can help people recover better from brain injury, stroke, Alzheimer's, etc. And you'll see that a lot of the data that might be presented this weekend might come from these other disciplines. Why should you care about regenerative medicine? Well, if you've been practicing pain management long enough, you'll recognize that a lot of the procedures that we perform are based on very catabolic tendencies. For example, we inject corticosteroids and local anesthetics, which have been demonstrated to be incredibly toxic to soft tissues. We burn or cauterize or radiofrequency ablate nerves and tissues that send signals to the brain. Now, what else do those things do? Well, they certainly can injure the bone and the soft tissue surrounding those nerves. What is it about regenerative medicine then? Well, namely, we try to remove these catabolic tendencies for what we are doing, in our interventions, and replace them with things that are going to be pro-anabolic, to grow, heal, and provide a regeneration of the tissues such that further injury does not occur. Now, where can you put this stuff? And where is there good evidence for it? Well, there's certainly great evidence looking at treating the musculoskeletal system. There's also evidence out there looking at utilizing regenerative medicine to treat the hair and skin. Where else can you use it? Now, although I do not practice some of these other topics that are going to be discussed, there certainly is a growing body of evidence that suggests that you can treat sexual dysfunction disorders, as well as augment certain aesthetics that you may be interested in. And some of our talks during the conference are going to be going over this, and I hope you'll enjoy them. One definition for chronic pain is that it's pain that persists after an injuries heal, and the pain persists for no apparent biological cause. Essentially, you can sum it into the pain that extends beyond the expected period of healing. Now, my question for you is, why does that occur? And is it because the body has given up on trying to heal that injury? Has the body not only given up, or does it have not the ability to? And the question, therefore, that extends from that, is it impossible for the body to fully heal those injured tissues, or is there something that we can do to jumpstart or restart the healing process? I'd like to take a moment here to talk a little bit about image guidance. This image on the top left is from someone who posted it on Instagram, stating to be a world expert on regenerative medicine and performing procedures. You might notice that there are two people in this image, and there's some cognitive and physical dissonance between where that ultrasound probe is and where that needle might be. Now, I make this as a point because it is a big deal in regenerative medicine, because most of the tissue targets that we target or that have the best evidence for are the soft tissues, the tendons, the ligaments, the cartilage, etc. And so it's typically important to do well in regenerative medicine to try to learn how to use this modality. This image on the top right is myself during a live course treating someone's common extensor tendinopathy. Now, what is it else that you can do with ultrasound? Well, you can diagnose a lot of musculoskeletal problems. And what I think is important for you to understand in that is that you don't see what you don't know, and you'll never be able to fix what you don't see. So you should think about learning how to incorporate this into your practice. How do we perform regenerative medicine? Well, it could be as simple as hypertonic dextrose solution, which Dr. Andrew Trescott will discuss, or you can utilize platelet-rich plasma, or bone marrow concentrate, or adipose, microfractionated adipose tissue, or allogeneic tissues. Now, you have to understand that within all of these categories, there are multiple variabilities or multiple variations on how you combine your dextrose solution, or how you have your PRP, your bone marrow, your allogeneic products, which are probably over dozens out there. And so you have to understand what makes each one of these unique and special, and what are they best indicated for. How else, or what else actually, is important in incorporating regenerative medicine? Well, you're going to need to learn how to do the procedures. There's obtaining the PRP and figuring out how to get leukocyte-rich or leukocyte-poor PRP, what dextrose solutions and concentrations or additives might be beneficial to your indication. You're going to need to learn the technical expertise on how to perform these procedures after you've even obtained the injectates. And are you going to use ultrasound or fluoroscopy to perform the interventions? The equipment and materials that are necessary for regenerative medicine that we're going to be discussed, you'll understand that there's going to be differences between the adipose and the bone marrow and the allogeneic tissues. And what is the difference between them? What are their pros and cons? Which ones are pro-chondrocytes? Which ones are less? We are going to be fleshing these topics out during the course of this weekend. Now, how are you injecting it? And this kind of comes back to my last slide regarding utilizing some type of image guidance. You'll notice in these images, there's someone performing what looks like blind or anatomic-based injections into the deltoid muscle. Now you'll notice that there are multiple red spots there. And these are screenshots from a video that I took, or a video that I found on the internet. And I'd just like to point out that although this is probably classic for some prolotherapy protocols, you can imagine how this might be of concern as to accuracy of injectate, as well as questionable efficacy based off upon that. And this comes to us looking at something like the meniscus. The meniscus is between the end of the distal femur and the proximal tibia. You'll notice that there's two parts to it in general, what we call the white zone, which is on the left side of the screen, and what's on the right side of the screen, or superficial or lateral to it, which is the red zone. The red zone has peripheral capsular blood supply, which gives it a way for vascular access into that meniscus. It is known because of this vascularity of the tissue that the red zone is going to have a better capacity for healing naturally, as well as from regenerative medicine interventions. As an example of this, you'll see on this MRI here where there's this meniscus that has extensive disruption right through here. And you'll notice that right down the middle, we have this fissure that creates this large lesion. And this is the same patient here on the bottom with what we were looking at the medial knee, where you have here, we have the medial meniscus, which has been extruded out, and it is torn right down the middle. as well as having disruptions of the fibers that attach it here and the fibers that attach it here. That, in conjunction with this edematous medial collateral ligament, is what caused this patient to have severe, ongoing, nagging medial side knee pain. Now, this is my own knee, and I've injected it multiple times now over the years with platelet-rich plasma and hyaluronic acid, and I've actually been able to offset surgery and function at a relatively normal extent. Here's an image of that same medial meniscus a few weeks after the first time I injected it. After the second time I injected it, but the first time I injected directly into my meniscus. You'll notice that the edges have lost a lot of the edema. Now, I cannot make torn fibers reattach. You'll notice there's still fluid in here, and I cannot make torn fibers reattach over here. This is the meniscotibial ligaments. But you'll notice that my MCL has greatly improved and a lot of the edema has been reduced. This is approximately 4 to 5 weeks after that same injection you saw on the last slide. I'd like to present one more case. This is a 45-year-old competitive CrossFit athlete. He had a history of bilateral knee pain. In one knee, the left side, he had arthroscopic scope, which benefited him to some degree, but he still had residual pain. He presented to me with a chief complaint of right knee pain. And he reports that the pain is both medial and medial anterior and posterior medial. He stated that the medial knee pain was brought on with heavy lifting, such as performing deadlifts, or drops from height, walking upstairs and walking on the stand. The posterior knee pain was deep and worse with ambulation and walking downstairs. On examination, he had medial joint line tenderness. He had pain with deep knee flexion, pain with valgus stress, and Thessal's maneuver. In the posterior knee, he was tender in the posterior fossa extending to the posterior medial tibia. Now, I'm very descriptive here because I want you to keep in mind that when we're performing these injections, our diagnosis has to be spot on. If your intervention for knee pain is always the same intervention, despite having multiple different areas that can hurt or be injured in the knee, that might be a reason why your interventions might not always be as successful as you'd like them to be. This is that same patient's knee. And I just show this because here we have, again, the distal end of his femur. We have the proximal end of his tibia. We have a small sliver of anechoic cartilage here and here that you can make out. Now, in between them, what this is then is his medial meniscus. You notice there's a few things that are going on here. It looks almost like a bear claw. And so certainly it's been fragmented. The fibers that attach it to the tibia, the femoral ligaments are disrupted, and the meniscotibial ligaments are certainly disrupted. And there's a little bit of edema in his MCL. Now, what did I do for him? He had a large joint effusion, and I aspirated over 10 milliliters of serosanguinous synovial fluid. I then utilized a leukocyte PRP and injected into his meniscus fissure. I addressed his meniscotibial ligaments, meniscofemoral ligaments, and I injected into his medial collateral ligament, both in the superficial and deep layers. I also treated what is not shown in these images, but his LCL and his popliteus tendon insertion, which is what was causing him pain on the lateral and posterior aspects of his knee. At the very end, I put leukocyte-poor platelet-rich plasma into his joint space. This is that same patient, approximately 5 weeks out from the procedure. This image is just showing a little bit of what's going on in his knee, but you'll see that the edema in his medial meniscus has been greatly diminished. And again, I cannot cause these completely torn fibers to reattach. And I cannot cause the completely torn fibers on this side to reattach. But you'll notice that some of the edema is gone. He might still have a little bit of this bear claw shape to his medial meniscus, but it certainly looks better than the last image. If you do have fibers that are still hanging on for dear life in this area, or slightly injured, we can definitely help some of those. And you might not be able to identify those specifically in this one slice. Here's his popliteus tendon in the posterior aspect near its attachment point. You'll notice that I have this needle going out of plane, injecting near the attachment point. In this bottom right image, you'll notice that I'm injecting also continued out of plane, but above the distal, the distal insertion of the popliteus tendon to bathe the entire tendon. At approximately 5 weeks, we see how this patient is doing. You'll notice that he's standing in this image without any straps around his knee. What he's demonstrating here to me is how far he can bend his knees and that he can get his butt below the level plane of his knees. He's gone back to heavy resisted weight training. You'll notice how far he can get with his buttocks past the plane of his knees. That last case was looking at the knee, which is one of the most common things we are evaluating in pain medicine and orthopedic medicine. In this top left, we have a patient with four-tendon rotator cuff disease, severe tendinosis, rotator cuff tears, and glenohumeral joint arthritis. We treated him during a live course with bone marrow bone marrow mesenchymal stem cells, and he's done markedly well. If you're interested in learning about my practice, you're welcome to check out my website, gccinstitute.org, or follow me on Instagram at RegenMedDoctor. Thank you, and I hope you enjoy the rest of this course. Thank you for spending your weekend with us.